Welcome to this Adobe Connect session. Tonight I want to talk a little bit about the functionality of the nephron, how the filtrate happens and what happens to the filtrate that ends up causing reabsorption, secretion, and finally elimination as urine. And so this is just a quick picture that you have in your reading guide material that shows the blood flow and as it comes into the glomerulus, the series of capillaries in the Bowman's capsule. And often we hear a reference such as this acts as a sieve or perhaps a colander. For those of you that cook, that might make a little more sense. Or if you're cheesemakers, cheesecloth, where you're putting a substance in and you're wanting some of that substance to leave, like in a cheesecloth, you want the water to drip out. Or in a colander, you want the dirts and the bugs and things like that to leave from what you are rinsing. Or, if you're doing pasta or something, that the water leaves. That same type of thing's happening here now. The filtrate, part of the blood that comes out into this little space here, has to do with size and charge. So things that are too big and things that are differently charged sometimes don't come out. We still see both negative and positive in the filtrate, but for example, proteins, they're large, but they're also highly negatively charged, and so they don't have a tendency to want to pull through, but they also wouldn't have this space to pull through, so to speak, because of the size of the holes, is what we're going to call them. We're going to keep with the colander analogy for now. The same goes with red cells and white cells and platelets. So the formed elements and large proteins, typically we don't see any of that in the filtrate at all. If we do, then we know there's a problem. So for example, if there are proteins in the filtrate, then there's a possibility that there are some kidney damage um, concerns, because we wouldn't expect to see proteins in the urine at all. Another thing we wouldn't expect to see is blood. Now, when we see red cells, and that's what I mean by blood, is you see that physical red cell, which then gives the appearance of blood. There would also be concern that there may be some kidney damage, that there's not much else in the urinary tract or in the bladder that would cause that without a known injury, like someone hurting you or stabbing you or surgery or something, that type of thing. With white cells, if we see those in the urine, we most likely think, though, urinary tract infection or bladder infection. We don't often associate that with kidney damage. It may be part of it, but more often than not, it's usually associated with a painful urination, and then that's another clue that there might be a urinary tract infection or a bladder infection that can be treated, and that's why the white cells are there. Just a little side fact, women are more often apt to get urinary tract infections than men. Men actually, as we'll learn in the reproductive system, have a associated gland with the seminal fluid that contributes towards semen, that actually has a natural antibiotic-like factor in it. And we'll talk more about that and where that comes from. And so it actually helps keep that tract clear. That tract also is shorter, so there's less likelihood of seeing problems there. So just like I said, a little factoid. But we're going to go on from here. I'm going to pull up a nephron in just a second and see if we can get this to come up. And kind of step back and take a big picture. So when I say a big picture, I'm often talking about the forest and the trees. It's one of my favorite analogies because I'm more of a forest person. My husband's definitely a tree person. So we have to remember that perspective when we're having discussions. But I think it's important too that we step back and kind of look at the system or look at the anatomy. Sometimes we're so focused on the details and so focused at the cellular level we kind of forget. But I really love this picture of the nephron because it shows here's the beginning with the glomerular capsule and so forth. But we see that the blood comes through, like I said, series of capillaries here. These little teeny arterioles, though, go all through it. So as we go through and just enter and kind of follow, it's kind of like those things that you used to do as a kid. Proximal convoluted tubule, and indeed it's convoluted, although we often show it very neat. It comes down to the loop of Henle, up through the ascending or distal convoluted tubule, an ascending loop of Henle, over to the collecting duct here. But as you can see, it's all kind of convoluted, and there's blood vessels, arterioles, all throughout this area. And so what we actually see is this continual reabsorption back into the blood, or in the case up here, upper distal convoluted tubule and collecting duct, we actually may see some secretion, some other substances coming from the interstitial fluid and from the vessels into the tubule. And so I think this gives us a better picture of how that's happening. When we stretch it out, it's kind of hard to see or understand. Well, when it's reabsorbed, where's it going to? And it's actually going right back into these vessels, as you see. Eventually, some capillaries will be here between the arteries and the veins. All right. Okay, this image we're going to just stay for a little while. This is what I was referring to, that sometimes we kind of stretch it out a little bit so it looks like it's this one continual loop, which it is, but in the sense that it's segregated. And we're trying to stay away from these kind of pictures you'll see in our reading material. We've tried hard not to show it as just this, tubule here, down here, down here. It's actually very convoluted and better to see the whole picture type of thing, but then still understand what's happening in the different sections. And so we're going to go to another one, hopefully with a little bit better resolution. Here, let's see, that we can discuss a little bit. This kidney physiology is one especially for pharmaceuticals. Companies, R&D, all that type of thing, it can be very useful because of its ability not only to reabsorb things, but to have secretion. And part of your reading guide and study guide a little bit later, we'll talk about cretin clearance and things like that. And if you're in lab, you're learning about that this week. And while this is not the focus of this particular Connect session, this still kind of brings in some extra things that may find useful. But what I really wanted to do right now, at least for our initial purposes with this session, is to talk about what happens through the trip of this tubule. So it's one long tubule, but very connected. Once again, we've kind of stretched it out so we can talk a little bit more about it. This specifically is talking about diuretics and their site of action. So if you're interested, you can look at that later. But what we see is the filtrate, if you remember that picture, has this little opening here in its proximal convoluted tubule. And in this section of the nephron, almost immediately, we start getting reabsorption. In fact, 100% of the glucose, which is a small molecule that it actually fits the criteria and goes into the filtrate, is 100% reabsorbed right in here. This is one of the reasons why when there's sugar in the urine or glucose in the urine, it's a concern and a very good indication that perhaps a person has a type of diabetes. Now, there's several types of diabetes, and we're going to go over that a little bit later. But if the body has the inability to pull all of that back and reabsorb it, then that means there's so much glucose in the system that it can't do it within its regular rate. Now, the GFR, glomerular filtration rate, is about 125 milliliters per minute of filtrate that goes through and gets essentially reabsorbed, and once again, other substances will get secreted later on down the line. But that's one that is an easy test to do. Way back in the old days, I know I was taught that those were old days too, but I mean way back in the old days, in order to test for someone with diabetes, they used to taste the urine. And if the urine tasted sweet, they would, that's why it's called diabetes mellitus. Mellitus coming from a word for honey. And so it was the idea that you had this excess of honey or excess sweet in your urine. Diabetes insipidus, which is a disorder that we talk about in this system as well, is where you have an excess of water when you don't have ADH, which is another Connect session, but just so you know. So you can have diabetes mellitus type 1, which is where your body has some autoimmune response and destroys your beta cells, your inability to make insulin. Type 2, which is often associated, it's not always, but there's a high association with obesity, where your insulin receptor cells are probably a little less sensitive. That's one of the prevailing theories. Or that your insulin is actually being absorbed and stored in the fat, and so there's not enough circulating insulin to really take care of the job. Those are a couple of the prevalent theories for type 2. There's gestational diabetes, which happens due to the demand of the fetus on the mother, and that's, just depending on that. What the correlation we see is individuals with diabetes, gestational diabetes, so during pregnancy, they're more likely to get type 2 diabetes later on in life. So they're having an intolerance. And it may happen with the first, it may not happen with the second, it may happen not until the third, and it may happen once it happens though. It's more likely to continue. It's not necessarily always the case, but it is more likely to continue. And it may continue earlier in each pregnancy as well, or may express itself. It just really depends. But there's a couple different types. And we'll talk more about diabetes near the end of the week and the beginning of next. So before this end of the module, I'll be posting some more information about diabetes in general. Anyway, so 100% glucose, that was a long way to explain that 100% of the glucose gets reabsorbed here in the proximal convoluted tubule. We also see other substances getting absorbed. We talk a lot about ions and other things. We're concerned about a few of them. Specifically, we talk a lot about sodium and chloride, potassium. These are all ions that are very useful in our system and have some physiological importance, so to speak. So we see that there's a bunch of those. And in fact, one of your reading guides, and we're trying to find out which one it is here, in filtration, reabsorption, and secretion, has a lovely table that you should pay a little bit of attention to that talks about reabsorption and what percentage gets reabsorbed in what area. And I mentioned this before somewhere, but wherever sodium goes, water follows. So when sodium gets reabsorbed, water will follow through. So we're also reabsorbing water at this point in time. So reabsorb glucose, a lot of the nutrients. It's your body's way, I think, of anything that's in the filtrate that's really necessary, like glucose and certainly certain ions. We're going to get that right back into the blood and get it reabsorbed right away. And a lot of that occurs here. The majority of it occurs here in proximal convoluted tubule. Amino acids, that type of thing. So as we hit this descending limb, so we're still in the PCT, but we're going into the descending limb of the loop of Henle. Sodium and chloride and potassium and water continue to be absorbed at this point in time. At the loop of Henle, we see that there is a lack of water reabsorption, but we also have this recirculating gradient. It doesn't really show here, but what we see is that sodium leaves, water follows. That changes the osmolarity within the tubule itself. It becomes much more concentrated as the water leaves. Even though sodium's leaving and other ions are leaving, there's a large concentration here. And as the water leaves, it gets it more concentrated. Well, if you recall from 264, the term osmosis is defined as the movement of water from a low concentration to a high concentration of solutes. And so as you get a high concentration of solutes, the water will have a tendency to move back through due to osmosis. And so you start getting this, like I said, recirculating gradient where water leaves and then water enters and water leaves and water enters. But overall, because of the amount of ions that are leaving, the amount of water that's leaving, we see the osmolarity change to very, very high levels here. And I'll show you a different figure with those values in a little bit. As we ascend, we get more sodium, chloride, potassium out. But this area here now becomes fairly impermeable to water. And the only thing that changes that is the influence of hormones, which we'll discuss in another Connect session so that this one's not too long. But so because of that, so these salts are leaving, but the water is staying, the osmolarity within the tubule starts to decline and it starts to dilute. Now we all know that, or we should all know at this point, that urine can be either very concentrated or very dilute, and a lot of that depends on water balance. What kind of water do we need to maintain in our system? If we're dehydrated, we're going to not release as much water. If we're overhydrated, or if other things are happening, we're taking medications like a diuretic that causes us to lose water, then it'll be more dilute. Or if you're ingesting tons of water, then you'll get more dilute urine. But once again, this area here, impermeable to water. Over here, where you'll see that it's based on hormonal influence, whether or not water is reabsorbed or not. And as the distal convoluted tubule here, you'll notice we're still showing solutes coming out, a little potassium, calcium, magnesium, sodium chloride, that type of thing, calcium. But here is where we start seeing, and don't look at the hormone things yet, but we start seeing secretion occur. So potassium and hydrogen ions specifically will come in here at the distal convoluted tubule as we enter into the collecting duct here, as well as toxins. So, you know how we have a lot of workplaces have drug tests and they have to urinate into a cup. Well, those toxins are broken down by the liver, and then that gets secreted at this point in time um, into the tubule, so into what will become a urine, and that's where you see that is in this area here. The collecting duct continues to gather all of that, what's left over in the filtrate, and ultimately that gets stored in the bladder and comes out as urine. So just a really brief overview of what substances are coming through. I couldn't get the table to reproduce, but once again, that's in your reading material. And it will tell you which segment, and based on sodium and water, essentially, it's really only doing sodium and water, but you can get a good idea of how that's being reabsorbed and why that's being reabsorbed. So let's go to the diagram that we have for you. Let me grab that one so we can kind of see the differences here. Just a second. Gotta get over to it. Yeah, lots of folders. Okay, and this particular one doesn't let me see the pictures, so hang on just for a sec. I know this is really exciting Connect session time, looking for pictures, huh? I just have to remember what it's called. Okay, where are you? There you are. Okay. So this is a diagram that we've given you to kind of give you an idea of the change in osmolarity. Just as a refresher, so molarity is the concentration of a substance in a liter of water. Osmolarity is the concentration or idea of the amount of particles in a substance. And so, for example, glucose is always glucose, it doesn't divide. And so the osmolarity and the molarity are the same. A sodium chloride, on the other hand, in water will dissociate completely. And so the osmolarity will be twice the molarity. If you have a 5 molar solution of salt water, if you talk about its osmolarity, it would be a 10 molar solution. So it's the number of particles. And that gives us a better, I think, understanding when we talk about the body systems, what's really happening, because we can talk about molarity concentrations, but that's specific to a chemical or a compound. Where in our body fluid, our interstitial fluid, and in the blood, we're taking into account all those different substances, whether it's something like glucose, or whether it's bicarbonate, or whether it's sodium chloride. And so to get an overall picture, we could look at the number of particles that are in solution in water. And normally in our body, we see about 300 milliosmoles. This is actually really important and a key concept to understand, because as we put things into our bodies, if you recall from tonicity in 264, if something's hypertonic because of osmosis, you'll actually cause the water to come into the cells or into the area, which may cause swelling, and to the point where you lyse the cells, you burst them, because the concentration difference is so great. And if it's a semi-permeable membrane where water can come in. On the other hand, if you put in a hypotonic, so something that's less than what the body is, what happens is the water in the cells and in those interstitial areas have a tendency to move towards that, what you've put in, and because of that, you can crenate or cause the cells, for instance, the red cells, to shrivel up. And so when you're prepping IVs, when you're putting any type of substance, artificial liquids or mediums into the body, you need to make sure that it's an isotonic, unless you have a desired effect to do one or the other, that you watch very closely that it's close to 300 milliosmoles. Once again, as a side note and a little advance into reproduction, when we do in vitro fertilization, where we take the eggs and put them into a petri dish and fertilize them in that petri dish and then put them back, that media all has to be, it's actually very slightly under 300, and it's very closely watched, that it's calculated and formulated to make sure that it matches that and tested. Now we all use commercial media and they do all that testing for us, but back in the old days, before commercial media was really popular, we had to make it ourselves, and we had to use an osmometer and test it, and test several samples to make sure that it was at the right osmolarity in order to be inserted, or in order to have those, the egg and the sperm in there without damaging those cells, without having, something happen. In fact, one of our tests uses that idea of hypotonicity, hypoosmolality, to see if if the sperm membrane's intact. It's a membrane function test, and we put it in a hypoosmotic solution, and that allows the water to go from a dilute to a more low to high concentration. If the membrane's intact, the heads will swell. If it's not, if for some reason it's damaged or if the sperm is dead, then it stays the same. It doesn't have any net movement of water. Anyway, sorry for the tangent, but important practical applications for osmolarity. Now here in the nephron, we kind of view it as a sense of, here we have 300, we're pulling ions out, but we're also pulling out water. We're seeing a little bit less here, but as we start to descend into the loop of Henle, notice how it gets more and more concentrated. And if you recall, we talked about the fact that where sodium goes, water follows, but we also see this recirculation gradient where water comes in, but water comes out, but there's more solutes leaving, so you're seeing a much, much higher concentration of osmolarity. Now, here as we ascend in the loop of Henle and start going into the distal convoluted tubule, water, there's no permeability here at all. And so as solutes continue to leave, such as potassium and magnesium and sodium and chloride, though it becomes less and less concentrated until it can be very dilute. Now, depending on circumstances, once again, will depend on whether or not in the distal convoluted tubule and the collecting duct, as it mentions here, is regulated. It's regulated by hormones and other control mechanisms, and it may vary. It may vary based on the amount of water, once again, that we want to retain or not retain, what hormones are being released. And we're going to look at that in another Connect session probably tomorrow. And so just know that, once again, we have these water reabsorption or sodium, which then when sodium leaves or is reabsorbed, then water follows in order to maintain water in our bodies. There are substances that help us excrete extra water, and like I said, we'll talk about those. So this is another one where we've stretched it out a little bit, but at least we show the vessels all throughout and get an idea of the osmolarity and permeability here of water reabsorption. So this is a really good one to learn and to think of. Okay. I just want to show you this one also is one of those that's trying to kind of put it all together for you. It's a little overwhelming, so we're just going to look at it just to see that we have the substances coming in. It shows you, don't need to worry about the plus and minuses. That has to do with pharmaceuticals. But, the glucose and ions and water come out, amino acids, and then water and sodium and glucose, or not glucose in the loop of Henle. That's already taken out. And then sodium and chloride, but no water. And then a lot of things, who knows what's going to happen depending on hormonal changes. But then potassium and hydrogen and other toxins are secreted at this point in time, and sometimes also here in the collecting duct. And then finally, any last minute changes based on our water needs and our storage needs for water, and those are all regulated by hormones here. So like I said, this one's a little more confusing, a little bit more complex, but that way it just gives you yet another visual to see. All right, so that's a little bit about the trip through the nephron. You should understand glomerular filtration rate, or GFR, clearance rate, which is in another section. As far as there's certain substances have different clearances. There's a great story about Warwoltru and penicillin, which actually can relate for those of you that have lab this week, or you can relate what you learn in lab in here this week. And essentially that your urine can be dilute or concentrated. A lot of it just depends on the needs of the body. Remember, this is part of our waste production. We have elimination in one of three ways normally, through the feces, through the urine, and then through sweat, although we don't do a whole lot of elimination of toxic substances or waste products such as, and the respiration system, of course, with CO2. But when we're talking about, ions and toxins and things like that, we see that elimination in both feces and in urine mainly, and then CO2 with respiration. And so important to understand what's happening and why it changes that composition and why certain things cause change. cause it to change. So, and we'll talk about water balance and water control in another session. See you then.